for the masses began with vision from our forefathers with the establishment of the Faculty of Medicine at Chulalongkorn University in 1947. For over 7 decades, MDCU has been home to the country's most innovative medical and scientific researchers. Paving the way for medical excellence and to offer adequate and accessible health care to all mankind, we have made daring efforts to develop and promote medical breakthroughs ranging from HIV, rabies, tropical diseases, family planning, and sexual reproductive health for women and adolescents, to the latest breakthroughs in cancer, genomics, and rare genetic diseases, reaching to the COVID-19 pandemic. We at the Graduate School of Global Health at the Faculty of Medicine, Chulalongkorn University, capitalize on our proven depth of expertise in each respective field to prepare future leaders for global health challenges. The unique courses and modules offer medical, healthcare, and public health professionals from around the world a tailored approach to the latest global health and public policy disciplines. Global health perspectives are cultivated and delivered from a local and regional vantage point to help promote health equity and accessibility, as well as to reduce the economic and infrastructural burden of healthcare in developing nations. Together, we can build new healthcare systems to support the increasing demands of the 21st century. At the Graduate School of Global Health at the Faculty of Medicine, Chulalongkorn University, we care with our broad vision. We dare by doing, and we share our expertise with the rest of the world. Join us today.
Good afternoon, everyone. My name is Grisada Wutikan from the School of Global Health, Faculty of Medicine, Chulalongkorn University. I'm extremely delighted to welcome everyone to the 4th School of Global Health Lecture Series today, which is co-hosted by the International Doctor of Medicine Program and the School of Global Health at Chulalongkorn University. To make it more special, today we have an internationally renowned guest speaker, Professor Michelle Williams, with us today. Professor Williams will share her perspective on a very important topic. Before we get to her talk, first of all, I would like to invite Professor Wacharsin to welcome everyone and introduce our guest speaker for today's special SGH Lecture Series. Please, Dr. Wacharsin.
It is my honor to introduce our speaker for the School of Global Health Lecture today. Professor Michelle Williams is the Dean of the Harvard T.H. Chang School of Public Health. She is a renowned epidemiologist and award-winning educator and widely recognized academic leader. Her scientific work places special emphasis on the area of reproductive, perinatal, pediatrics, and molecular epidemiology. Dean Williams has published more than 500 scientific articles and was elected to the National Academy of Medicine in 2016. She has an undergraduate degree in biology and genetics from Princeton University, a master in civil engineering from Tufts University, and master and doctoral degree in epidemiology from the Harvard Chang School. With the establishment of the new School of Global Health, we are much privileged that Dean Williams kindly accepted to be our scientific advisory committee. Especially today, she dedicated the time for her busy schedule to be with us at the Faculty of Medicine, Chulalongkorn University, and to be with our students, both undergraduate and postgraduate levels. Dean Williams will give us the insight and discuss with us about the Global Health Board agenda. Please join me in welcoming Dean Williams onto stage.
And before we get to Professor William talks, I would like to thank Dr. Wacharasin for a very warm welcome. And just to remind everyone about a general housekeeping, we will leave the question and answer session at the end after her talk. And if you have any question, you can either write down or raise your hand at the end of the session. Without any further waiting, I would like to invite Professor Williams to share your perspective on the topics today entitled Global Health Bold Agenda, a conversation with Dean Michelle Williams. Please, Professor Williams.
You can hear me now. It's good to see you. For me, this afternoon is a very special afternoon because I get to return to my second academic home, Chulalongkorn University. I have a very long-standing relationship and fondness for this institution. Many, many years ago, when I was a junior faculty member, I came to visit this university, and I visited Professor Priyom at the time. And I introduced myself, and I shared with him that I had a bold agenda of wanting to understand and learn from my colleagues here in Thailand how to be a global professor, how to engage in global health through collaboration in sharing the things that I know and learning from others who know things that I did not know. Professor Priyom was very generous. Professor Priyom introduced me to several of your colleagues who are here, including the head of OBGYN, who welcomed me into the department and into the School of Medicine, where I was able to develop strong relationships that are now approaching 2 decades, and was able to share in learning and teaching, listening and experiencing what it means to be a global health professional. So I have a very deep love, fondness, and gratitude for this institution. So thank you for inviting me back to give this lecture and to have this conversation. I also want to thank the faculty of the new School of Global Health here at Chulalongkorn for inviting me to be a participant in this exciting new mission of the development of the school. Thank you very much for inviting me to share with you as you develop this wonderfully new, bold School of Global Health at Chulalongkorn University. Now, I say this to express my gratitude and my thanks, but I'm also delighted that I have an opportunity to engage in this conversation. A conversation that I hope will leave you all thinking about the choices that you make to engage in global health, whether you are an educator, a practitioner, or just a consumer of the information and the benefits and the science that comes from the work that we in global health do. I also want to recognize that we know that these are challenging times as we face the urgent and overlapping crises of COVID, which is not over yet, even though my president at the United States says it's over. Believe me, it's not over. I also want to recognize that we have and we are living and confronting the real impacts of climate change, which is a next big challenge that is right here on our doorsteps. And I see the impacts in just moving around Bangkok yesterday. In places that do not regularly flood are now regularly flooding. We also are facing the residual effects of climate change that produces food insecurity, and the effects of war and conflict that is causing forced migration and impacting food security. And of course, all of us are experiencing increasing rates of chronic diseases as our populations age and as the lifestyle changes in ways that the early onset of diseases of aging, which are no longer diseases of aging, they are diseases of living in a modern society, are becoming more prevalent. So I recognize very clearly that we have major challenges ahead of us. And now, more than ever, we need leaders. We need leaders steeped in the values and the principles of public health to guide us through. Those leaders have to be leading across all sectors, not just academic public health, not just clinical medicine, but in policy and in business and in all sectors that make up our civil society. So I am grateful to each and every one of you who choose this afternoon to spend your time thinking about the challenges and thinking about the solutions we have to bring forward to address these challenges. And for those of you who are interested in pursuing a career in public health and global health, I say welcome. And I say welcome and thank you because you are rushing towards an emergency. You are not retreating from the challenge, but you are preparing yourself to engage in addressing the challenge. As you know already, I am honored to serve on the Scientific Advisory Committee of the School of Global Health. It is a real privilege to be part of the founding group of thought leaders to engage in this design of this imaginative, bold, and very timely school. The fact that the school is being developed represents a commitment. It's a commitment of choice to enhance the career of people who will take on the challenges. And I have very strong commitment, and I am deeply impressed with Thailand's leadership on many of the public health fronts. And I want to share with you why I say that. How am I so impressed in Thailand's leadership in public health? I want to share with you a few of the reasons why. Because there's a lot to learn from Thailand's history in public health. Thailand's standing as a global leader in HIV prevention and treatment is second to none. In fact, its history is very well known. You do not have to look very far to see this. Thailand was one of the very first countries in Asia to recognize the devastating effects of HIV and AIDS, and Thailand acted quickly and decisively to stop the spread. As early as 1989, the government made HIV a priority on its national agenda. It implemented serological surveillance of the general population. We're not that far off track. Okay, so what I was saying is, as early as 1989, the government of Thailand recognized the importance of HIV being a public health priority on a national agenda. And it implemented serological surveillance of the general population and sentinel surveillance programs of high-risk groups and launched massive public health information campaigns emphasizing prevention, behavior change, and specifically the promotion of use of condoms. One of the most notable features of Thailand's response to this crisis is that the government involved the private sector with education campaigns in workplaces. Initiatives like the 100% condom program were also very notable and has been a case of study by many other countries. Because although sex workers, and they are still illegal, the country recognized that the program had to seek out and avoid driving sex workers underground and further away in the shadows, where they might be more likely to acquire HIV and AIDS. So instead, the program sought to meet sex workers where they are, and by doing that, promoted universal and consistent use of condoms in commercial sex work. What did that mean in terms of public health impact? It meant that the use of condoms in sex work went from 14% in 1989 to more than 90% just 3 years later in 1992. Public health has to meet everybody where they are. And this is a perfect example of a program that was designed with human beings at the center of the design so that effective intervention and prevention could be brought forward. I think this is a remarkable example because this example shows the best principles and approaches of public health, and it also shows the massive impacts in the number of lives saved as a result of a very careful and thoughtfully designed and implemented program. The program was also successful in large part because it was not just a government issue or effort, and it was not just an academic effort. Officials persuaded hotel owners in the private sector to make condoms available for use. The government also got movie and TV producers involved to effectively communicate to people across all sectors. It involved even invoking religious leaders, Buddhist monks who were enlisted to bless condoms with holy water. And so you see, the effort was to have a completely comprehensive, humanistic approach to a problem. This, I think, is an impressive example that those of you who are new to public health must learn and appreciate. This next slide, I want to talk about Thailand's response because it was bold. It was cross-cutting. It cut across all sectors and industry. And it worked. Together, these policies helped significantly to reduce the new cases, not just HIV, but also other STDs, sexually transmitted diseases. And in fact, a study in 1998 found that HIV incidence had declined by 5 times among men between 1991 and 93, while STD incidence had declined by 10 times during the same period. So these interventions had across the board multiple impacts. And indeed, Thailand's rapid and effective HIV response showed other countries around the world a pathway forward. I want to take a look at another program in Thailand. And I know that this one, I was here in the country when we were just beginning to implement the 30 baht program. And as a Westerner, I was thinking about the exchange value. And I was like, what? What can you buy for $1 in healthcare? I was very skeptical, and I know that this is a very important program, and it is a developmental process towards the country achieving the goal, the aspirational goal of universal health coverage. And I watched up close when I was in the country, and even today from a distance as I watch and learn how each different country tries to address health equity, health access, universal coverage. And there are very important lessons to learn from the 30 baht program because it underscores Thailand's global leadership aspiration in public health. And again, I think this serves as a living model for many countries in the world, including my own, where we still struggle with our own implementation of universal health coverage. So in 2001, and I want to go to the next slide, in 2001, before the 30 baht program was implemented, nearly 1 in 4 people in Thailand were uninsured. That's 25% of the population uninsured, which is about the same prior to the universal health coverage in the US. And while others had insurance plans, they were only offering partial protection. And as a result, over 17,000 children under the age of 5 years died each year, including 2/3 from easily preventable infectious diseases. And in addition, the high cost of healthcare was pushing many families into poverty. So the early impact of the program was profound. And again, I recognize there are challenges, and even yesterday I heard many debates and concerns. The implementation is not as strong and robust as we like, and the program is under strain. But you must recognize historically what has been achieved by this bold experiment of trying to provide universal health coverage. And I will give a brief summary. You know, the program, when it was implemented, extended coverage to 18.5 million people who had previously been uninsured. This is a very large population to try to bring into a health system where costs are always increasing. The program also shifted focus to primary care, reallocating resources away from urban hospitals focused on secondary and tertiary care towards rural district hospitals, creating more of an opportunity for access and equity issues in urban district hospitals and health centers. While most Thais benefited from the healthcare program, it was the poorest women in the country of reproductive age, who saw the biggest impacts. And in fact, a paper published in 2014, the authors showed that the reduction in infant mortality ranged from 13% to 30% across the country, with the biggest reductions occurring among the country's most impoverished people. So, as imperfect as the program is, and as challenged as it is today, its impact, by the time investigators were evaluating its impact on population, started to demonstrate notable reductions in infant mortality, and that these reductions were occurring in ways that closed the equity gap, the disparity gap in infant mortality for the poorest population in the country. So again, as imperfect as this program, it shows remarkable progress. That it was able to close an infant mortality gap represents an important experiment and lesson to take away for public health. And once again, I want to point out that the government did not do this alone. In fact, a faculty from Colgate University in New York argued in 2018 in a paper that was published that the health government officials at the Ministry of Public Health relied on policy knowledge, know-how, and network of local NGOs, non-government organizations, to design and implement the universal health coverage. And NGOs were also crucial in educating the public about health policy and mobilizing their efforts for pushing legislation. The success of the 30-bot program and the breakthrough speed in which it was implemented would not have been possible if public health officials had not chosen to develop ties and share their expertise with people outside of the government. In fact, the program also underscored the impact of that public health can have on the economy. Only 1 year after its launch, people in Thailand were less likely to report that they could not work because of an illness, therefore increasing productivity, especially among workers over the age of 65. There are many lessons to learn from this example, and indeed we are still learning lessons today. But an important one is that to design a successful public health policy, we must connect, we must exchange ideas, and we must work with people inside of public health, but also across many other sectors. And that public health policies developed in that way that includes collaboration end up not just improving health of the population, but having positive impacts in other areas, including economic development and economic sustainability. So I share with you these two examples because what I'd like to do is really use these to set the stage for the rest of my remarks. You have seen and maybe have heard already the title of my talk called Global Health's Bold Agenda. My core theme for this conversation is that collaboration across disciplines, across sectors, and indeed across borders and continents in particular, is central for our solving the biggest global health problems that we have ahead of us today. And that's because public health cannot work in silos. In a conversation I had with several of the faculty today, we started to talk about how important it is to be deep in our disciplinary training, but to be wide and broad in the way we practice public health. And this is absolutely essential for the work that we have to do in public health. Now, the COVID-19 pandemic makes what I just say very obvious, very evident. The pandemic had made it even more clear for me just how important it is that we are both deep and broad. And it has made it even more clear that we as public health people must be emboldened. We must be emboldened to declare that there is not a single sector in society where public health does not play a pivotal role. I, before the pandemic, would probably be a little bit shy about making that statement. But we have all lived through the last 2 years where we have seen what a public health crisis can do to all of civil society. It can bring us all to a full stop. It can drive us into our homes, away from our work, away from our loved ones, away from our education. And so there is not a single area in society where public health does not play a pivotal role. In fact, I have taken to saying to everyone, public health is not an opportunity for charity. Public health is a strategic pillar of investment because it is the bedrock of our civil society. And if we appreciate that and we communicate that, then I think we will all be better prepared for the next pandemic and for meeting the challenges that threaten the sustainability and the development of our society as we know it. So public health is critical. It's critical for our economic growth. It's critical for our security. It is imperative for national security. It is central to protecting our environment. It is connected to the success of student learning and to the ups and downs of worker productivity. And of course, public health is intimately interwoven in our personal health and in our well-being in countless ways. I would say in infinite ways. So, given that public health touches all sectors, it should be clear that we need a multidisciplinary approach to solving public health challenges. All too often in academia, and I know this because I am from academia, I have never really left academia, but we know that in academia, we tend to approach public health in disciplinary silos. You are an epidemiologist, or you are a health policy person, you're an environmental person, and even within these, you are a specialist within specialties. But this is not the way to solve problems. The way to solve problems is we have to become experts in our narrow field. We have to get grants for tackling the one things that we do to solve problems. We know that our colleagues are working on other areas in other departments. But again, if we are to solve the problems that are facing us in public health, we have to move beyond our silos. We have to move beyond the myopia of the expertise of our narrow field. And we have to see that the talent next door or down the hall or downstairs in other departments or the talent all around the world need to come together in effective, well-managed teams, and that those well-managed teams bringing their deep disciplines together to create the broad response that's needed. This is a problem that is to be addressed locally in a very hyper-localized space, but also globally, because the problems that we tackle are on global scales. And for too long, scientists in the global north have assumed that it is up to us, it's up to the global north to have the solutions. But that's not true. The solutions have to come from everywhere because the challenges are everywhere, in Africa, in South Asia, in South America, in Latin America. And for far too long, we have been blinded to the fact that there are enormous reserves of talent, ingenuity, and know-how and ideas from low and middle income countries. Because the truth is, and we know this, the pioneers all around the world have made scientific discoveries and developed very brilliant paradigms And these include the two examples that I just shared from Thailand, the 100% condom program and the 30-baht program. There are other cases to think about. And other cases of progress that have been seeded by investment in from the global north, which has allowed countries in the global south to dramatically ramp up their capacity and to unleash the talent that exists. And here I want to show you and ask you to consider a program called the Botswana Harvard Aid Institute Partnership, which was the first laboratory to identify Omicron variant and to alarm and to bring a notice to the world, alert the world of the existence of Omicron. The laboratory was established in 1996, and this lab now has 350 full-time employees. Harvard helped to launch this laboratory, but its local researchers took the lead and have been leading in the research and in treating HIV/AIDS in Africa. And when COVID-19 pandemic struck, the laboratory was well positioned with the right capacity to pivot its genomic know-how and surveillance in just 2 weeks. And in those 2 weeks, it turned out that the team's excellence provided an early warning system that helped the world prepare for the next stage of the pandemic. From this work, one of the African researchers, Sikeleli Moyo, was named Time Magazine's 100th most influential people in the world. I'm really proud of this because this is a perfect example of the investment of capacity building and then having global north leadership move out of the way so leadership capacity can grow, develop, and thrive. And this is just the kind of example where that kind of investment allows for all of us to benefit, because that early warning gave the global north the opportunity to re-implement very important life-saving public health practices to reduce the spread of the new variant Omicron that was hitting the globe in November of last year. So this is one example I wanted to share with you. I want to share another example, and this is another example from Africa. During the Ebola crisis of 2014 and 2016, the World Bank invested in a regional disease surveillance project that spanned 16 West and Central African countries. Under this program, the Institut Pasteur in Dakar, Senegal, was able to enhance its surveillance systems for all kinds of diseases. The Institute later became one of the first laboratories in the continent to be accredited by the World Health Organization for testing COVID-19. And as a result, they tailored dozens more laboratories across the region in West and Central Africa. Why is this important? Because this preparation of the Institut Pasteur in Dakar, Senegal, was able to allow for rapid expansion of capacity to produce vaccines and testing, not only for COVID-19, but also for other devastating diseases. And the investment in these laboratories in the global south will allow for production of vaccines like yellow fever. And by the years 2030, it is expected that with strategic investments from the World Bank and from the global north, that Africa will be able to manufacture at least 60% of the vaccines that it will need across the continent. This is important. We recognize that this is an ambitious goal, but it is within reach thanks to global collaboration and the recognition and the need for supporting the extensive talent that exists in the global south, but is not cultivated and not nurtured and supported because of lack of investments. It also needs to be recognized that in doing this, it is not just charity. It is the right and important thing to do as an imperative for global health. Linking the right resources across geographies can make an enormous difference in the health of people everywhere. And this is a very important lesson that we in global health have known, but this pandemic makes it even more clear and more urgent for everyone to know this. And I hope that I have shown you the value of collaborating across countries and the value of investing in talent everywhere. The returns on investments are enormous and are widely diffused and dispersed across the globe. Now I want to turn to collaborating across sectors. I have to confess to you that I never always practiced collaborating across sectors. It's hard. You have to learn different cultures, the business culture, different language, financial language. You have to develop a tolerance for teaching and learning, and you have to sometimes go slow to go fast and far. But I will tell you that I have learned in the course of my career that we cannot achieve the global health agenda without engaging all sectors. It's been a very tough road in the United States, and it's been very public. And we know that in much of the world, too, that you have to get the private sector involved in public health problems and solutions if we want to bring scale. And to be fair, it hasn't been easy to get public health to work with the private sector. Again, new knowledge, new language, different cultures, different values. But once again, we have to work outside of our silos. De-siloing the work we do in public health is absolutely essential. I also want to recognize that many academics and public health sectors think of CEOs almost as a different species. I mean, even myself, right? I talk about new language, new values. It's almost a species difference. But there's so little opportunity for us to really have impact without engaging and interacting with CEOs. There's an assumption that the private sector does not always share our value. I want to share with you that I think that's a naive and underdeveloped impression. We have to recognize that we have a huge problem if we don't work across the sectors. In fact, I want to share with you that from climate change to infectious disease to hunger to mental health crises that we are facing, we cannot make real progress in any of these without the help and the engagement of private sector. We need their knowledge. We need their resources, and we know they have lots of resources. And we also need their connections. In other words, we need to work together. Slowly but surely, we are going to have to make more progress in working across the academic and the private sector and the public sector. In fact, I want to share with you an acronym that I coined when I was working with the Gates Foundation Grand Challenge 2 years ago. In pulling together a panel to talk about the challenge of global health and pandemic response and climate change, I wrote remarks that said, we have to imagine a world where we go from just talking about public-private partnerships, which up to now have been mostly transactional, to talking about public-private academic partnerships, which is intentionally transformative. I believe we in academia have to and should play a very active role in these partnerships. And I want to give you one example. During the pandemic, I co-founded the COVID Collaborative. The COVID Collaborative are diverse teams of experts in health, education, the economy, the public and the private sector, and the academic communities. And we came together to work with state and local leaders in the US when governments failed to respond appropriately and adequately to the pandemic. We have worked to expand school-based mental health care. We have worked to produce research demonstrating that children who have lost caregivers as a result of the pandemic are more likely to experience mental health problems and are at higher risk for suicide violence, sexual abuse, and exploitation. We have collectively urged the Biden administration to support these children and families in meaningful and urgently ways. And we have continued to fill the void as global response has remained slow. For example, as the use of masks in the US became politicized, almost political sport, we mobilized the country's biggest retail and manufacturing CEOs, and we had them make nonpartisan statements about the public health value of wearing masks. CEOs stood up and used their platform and their influence, linking arms with public health people to do the work that our governments failed to do. This was very important, and I think this is only the beginning of the way public health and the private sector can work together to solve problems, together effectively. I also want to share another example. This is an example that I'm excited to see, and it's one that speaks to the importance of public-private academic partnerships. It's a project called Project Healthy Minds. My university, my school, is not involved in this coalition, but I think it has a strong potential, and so I'd like to hold it up as an example. Project Healthy Minds has brought together a stellar coalition of directors and advisors from diverse sectors in the US economy. There are academics, activists, and C-suite executives at global companies, all of them working together to take a multi-pronged approach to solving mental health care treatment gaps. Their goal is to build technology that will make it easier and quicker for individuals to access quality mental health care. They intend to apply this work to improve the care that's offered to employees as part of their benefits package. And they even want to develop a set of metrics that individuals can use to evaluate the company's commitment to mental health before accepting a job offer. Imagine where workers can evaluate the companies that they work for based on the company's commitment to the health and wellness of their workforce. These types of public-private academic partnerships I offer to you are essential for our global health security. Absolutely essential, particularly given the problems that we face. So far, I have talked about how to tackle global problems. I'd like to end my remarks with a to-do list, a list of problems that we need urgent attention to be paid. Protecting global health, particularly global health security, means securing environmental justice. It is about identifying and addressing the disproportionate risk from polluted air, soil, and water that communities, especially those in developing countries, have borne for generations. It is also about mitigating the deadly impact of climate change, in particular the impacts in the poorest countries, which have contributed the least to this global warming problem, but is poised and is actually suffering the most. It is about delivering humanitarian aid in times of crisis. It is about removing barriers to access to basic health education and health care and uplifting underrepresented communities in the process. It is about leveraging technology to gain new insights into the human body. Global health security requires teaming up with business leaders to shape the future of work and the world. It is about caring for those in need, including those who are homeless or who have been moved to migrate as a result of encroaching climate or conflict. Public health is about advancing precision nutrition, right? Even in the context of food insecurity, we have to think about what is the optimal nutrition for optimal health and human development across the life course. Our work in global health means developing vaccines to prevent the next pandemic and making sure those vaccines are equitably available to all populations, because we have seen some very horrible examples of vaccine nationalism that never again should we see that happen across the globe. It means combating antibiotic-resistant superbugs. And the list goes on, which is why I am always grateful to welcome incoming students to global health and public health, because you are running towards some of the biggest challenges that our generation has seen. I do recognize that it's daunting. It's a daunting list of things that public health will be responsible for. But I also want to say that what makes me proud about public health is that we truly believe and we truly are committed for public health being a bedrock for a thriving society. And in order to protect that society and allow it to thrive, we must absolutely commit ourselves to doing our own part, but also working together. At a time of rising nationalism, as I mentioned before, let's remember for ourselves that the best and the fastest way to learn is often to do the learning with each other and from each other. Let's seek to build relationships with organizations outside of our own countries and outside of our own sectors and even outside of our own fields. And with an open mind and a rigorous and audacious commitment to scientific rigor and quality, we can continue to change lives in positive ways. I do strongly believe, because I have lived it even here with this institution, from the very first day I sat with Professor Priyom and I said, can we work together? And his response was yes. I have lived and learned from the experience that we can work together, we can share vision, we can share our aspirations for health and dignity and social justice for every human in this world. But it does require the commitment to being curious, to being collaborative, and to running towards the problems armed with the commitment and the humility to try to solve the problems. Thank you for your attention.
Thank you so much, Professor Williams, for a very inspiring talk. And next, we'll move to the question and answer session. If you have any question, you can raise your hand and our staff will bring the microphone to you. And please introduce yourself.
Good afternoon, Professor. I'm Seth Pong, and thank you for your bold and encouraging lecture. Brief introduction about myself. My research area is digital health, and my current academic/startup business focus is in translating the US CDC diabetes prevention program here in Thailand using a digital health therapeutic platform, while ensuring its effectiveness in a different setting. So I would like to ask for your insights/recommendations regarding such digital endeavors in lower to middle income countries in which clinical evidence is still limited. Thank you.
Yeah. First of all, thank you for bringing your interest in digital technology into the public health space. We are at the very early dawn of understanding what digital health integration into public health and primary health care can be. There is a great deal of promise that integrating digital health will accelerate the opportunity for us to democratize access to the highest quality health. There is also the promise that integration of digital health done in a way that is secure and democratized will increase the information base upon which we can learn in real time how to evaluate the impacts of the interventions and make course corrections in ways that will optimize and speed the integration of digital health delivery into practice. I think this is an important time for us to also be humble, however, and to recognize that as we integrate digital technology into the health space, we must also recognize what the limitations are. And currently there are many. The quality of the information that is available on the whole spectrum of population is very limited. So we must always be humble in recognizing that the data are not likely to include all of the people that we want, and we must commit ourselves to making sure the data are as complete and as accurate as possible. The other thing we have to do is recognize that partnering is going to be very important, and we will have to learn as public health people who are not trained in business to negotiate to get the right balance so that the drive for profit acquisition does not overtake the drive for public health approach and imperative. This will take skills, and I believe as an educator in public health, our curriculum has to include negotiation practices and business practices and skills so that we can actively design programs that are doing good and doing well, if you understand what I mean. And it just doesn't happen because we wish it to happen. We will have to work towards it, and we will have to develop those skills to do it. So I applaud you for doing this. It's in the experimental stage, and there are opportunities for learning and taking the digital integration across all segments of public health and behavioral health. Telemedicine is an example, for example, where we can fill gaps in communities where there are no trained psychiatrists or specialists. But we will have to build an infrastructure and support that infrastructure, and we don't yet know the blueprint for it, so we have to learn and share the successes, but also the failures. Good luck in the work, and this is another beautiful area where public-private academic partnerships can be very valuable.
Good afternoon, Professor Williams. My name is Ponpilat, a second-year medical student. Thank you very much for your talk. I learned a lot. I was wondering, since you talked about the necessity of public health to extend across borders and across like political lines, I was wondering how we could do that better to have public health rise above like political or national conflicts, because seen in Thailand and like in the international relations landscape, we often see situations where where certain countries like or people if they were willing to work together across these lines, like we could have helped maybe like contain the pandemic faster or make vast improvements. Yes. But it's hard for them to if they're on different sides and someone makes a mistake, it's hard for them to like admit that they made that mistake or they need that help. Yeah.
This is a very important question. It's very sophisticated, and I think it's one that we have to always ask ourselves, especially during a time of pandemic. And I will share with you that the U.S.-China relationship has not been as warm as it had been in previous years. And the worst time for a political freeze to happen is during a pandemic, when we need global cooperation, information sharing, and doing that in real time. But I think we in public health have to do everything to rise above the political tensions and recognize that global health is a global enterprise that requires global cooperation. And there is such a thing as global health diplomacy. And global health diplomacy must rise above the political tensions of the day. And I will tell you that as a dean of a school at Harvard, when this pandemic was happening in the midst of very not healthy relationship between US and China, we committed ourselves, me as an academic at Harvard, and my colleagues that I had been working with for 20 years in China, and the students that I had trained who are back in China. And we committed to ourselves that above politics, we are academic and public health practitioners. And that as such, we are not burdened by the political challenges, but we are committed to work with each other. And we found ways to work with each other. We designed exchange programs. Even though we couldn't physically cross borders, we still connected across Zoom and shared data and modeled data and worked with each other. We used Zoom to continue teaching and learning from each other. And we even went so bold as to create a coalition in the middle of a pandemic and a politically strained time, a coalition of deans of schools of public health to illustrate our enduring commitment during politically tough times. Now, I say all of this because there is no real single magic bullet, but to remember that, diplomatic relations go up and down, but public health demands us to be consistent and to keep our North Star of collaboration and cooperation at its center. And I am grateful for the fact that when you have an education opportunity like this one, where a large number of your classmates are from all over the world, you are already starting to build relationships that you will leverage during times of your professional career. Never underestimate the value of the international training that you have. I know that I speak with your faculty leaders who value the importance of exchange programs, and even in the middle of a pandemic, built an international cohort of experts to guide in the development of the school. We as academics hold a very special place in global education and global response. So my response to you is there is a will and a desire to stay above the local, urgent, current political issues and to keep an eye on the global health agenda, which requires us all to work together.
Thank you so much, ma'am. Just one more short point. Sorry. So it's like, public health professionals cannot live in isolation of other sectors, right? Whether it's politics, government, or the business world. So I'm someone who tends to be, when I'm focused in the field, I focus in that field, and I don't have very much knowledge of the other fields. Yep. But I feel like since after listening to you, it's really important for if I want to be someone who can make an impact in my field, whether or like in public health, I have to constantly try expand my knowledge to know about the government, what's happening all around the world, or like in government, in political views, or in the business world as well, to be able to think of the best way I can work with them or to push forward the agenda, right?
Yes. You can't do it all yourself. I mean, you're going to be an expert in your area, but you can develop relationships and networks so that you can complement your skills and your know-how with the skills and know-how of people in adjacent disciplines or even distant disciplines. And remember, when you commit yourself to a career in public health, you're committing yourself to lifelong learning. When I finished epidemiology a long time ago, there was no discussion about AI or machine learning or high-dimensional data, okay, or satellite remote sensing. But in the few years since I've graduated, all of those things are now in the toolkit that we can use in public health. I cannot be the expert in that, but I can work with people who have that expertise and create a team where my deep skills in causal inference can be brought forward to the AI computational scientist who knows nothing about study design and causal inference. And I can work with the pioneer of AI at Microsoft and bring him or her into the public health mission, and we can begin to develop early detection systems for mental health illnesses. I'm in the middle of doing a very exciting study with the Apple using the Apple Watch and the Apple iPhone to understand more about women's reproductive health. I don't know anything about high stakes computer design and digital, data computation, warehousing, but I know that the team we have put together that has a reproductive endocrinologist, 2 of them, that has a physicist, that has a computational biologist, epidemiologist, and data scientist, that together we make an awesome team. And that is fun. And I am continuing to learn from these people, even though my degree was many decades ago. So there is a lot of fun to be had in working at the intersection of disciplines and at the intersection of sectors that I think we as academics and public health practitioners have the privilege of taking advantage of. But we have to be prepared in going a little bit slower, because you can go faster if you work with people who are in your discipline. But it will take more time to develop the relationship and the language, the common language, to work across the disciplines. But it is a lot of fun.
Thank you so much.
I think we have time for one more question. I think in the back.
Hello, Professor Williams. Thank you for your lecture. And I have a question, and this is more, I want to hear your opinion about the aspect of collaboration that you brought up between international entities, I'd like to call them that. In the examples you gave, I noticed a trend, right? It's like, I would like to call it asymmetrical collaboration, right? One might be more suited to a certain contribution and the other. In this case, I have a question about global health. If you dissect it to principles and missions, right? What global health encompasses and what are you going to do about it? With your experience, seeing global health from Thai perspective and now from the US perspective, is it an issue that perhaps global health means different things to two different collaborators? In that case, like, is that an issue? Does it have to be equal, I guess?
Yeah. That's a great question. We were talking about this at lunch. And it's not just global health. It's what is international health? What is global health? What is global health security? And honestly, I will say that if you are going to develop a meaningful collaborative relationship that will last over years or generations, you have to ask those questions. What does global health mean to Harvard University, Harvard Chan School? Why did we change our department name from international health to global health? Was it because Bill and Melinda Gates were giving a lot of money to global health and not international health? What is global health is very important. And, people will sometimes think that it's academic obsessing about words. But it is important that we have a common vernacular, a common language, and that we are very clear in what is in it for you, what is in it for me. This is something they teach in Business School 101. And we are not always being taught this in epidemiology and public health 101. But to make a good relationship in business or in public health, we have to have a very clear understanding of what is the social contract that we are making with each other. And it starts with what is the definition. For me, global health has always been asymmetric. And it's been asymmetric for sociological and historical reasons that we cannot erase over time. But we can make a commitment to do things differently than how people who said they practiced global health before. We can make a commitment to say what global health is not. For me, as someone who was born in the global South, I was from Kingston, Jamaica, and I emigrated to the United States. In the 80s, when I was a student and I was going out in the world, one of the first places I went was in Kenya and Tanzania. Everywhere I went in Kenya and Tanzania, I looked like the people there, but I come from the US, and they treated me like the way they had experienced US people. This was people who came in, parachute in, do the research, take the data, go home and publish, and never again come back to the community. And even though that was not me, that label was put on me because of where I am from. So for me, my first experience in global health was to define what I am not. I am not a parachute scientist. I come with the humble experience of wanting to do good and to learn. So when I made collaborations in Zimbabwe or in Ethiopia or here in Thailand, I came and I explained who I am as a person, who I am as a scientist, what my dreams and hopes are. And I would say, I would like to, in the case of Ethiopia, I wanted to learn rural health epidemiology. And my partner in Ethiopia, professor in community medicine, wanted to learn clinical epidemiology. I said, this is perfect. He can teach me what rural health demography looks like in practice, because I only knew it from the books. And I can begin to integrate clinical epidemiology and biomarker epidemiology into his setting. It was a perfect match. It is a match that continues 20 years later. When I came here to Thailand, I said, I have never worked in Asia before. I have no skills. I would like to learn the culture, and I would like to be of use. And we had multiple conversations over wonderful meals, and we developed a blueprint for collaborating. So it takes time, and it takes designing something that is meaningful and mutually beneficial. And there is no other way to learn this than to do it through practice. You can read case studies, but to really be effective, you have to do this, and you have to do it with a guided, open mind that you have something to give, and you have something to learn, you have something to teach, you have something to learn. And for me, it's the most enriching experience in my career, is to be engaged in exchanges of students, exchanges of faculty. And I treasure that. I think it's a privilege. But you're absolutely right to ask about definitions, and you're absolutely right to recognize the asymmetry. And that asymmetry will exist until we address the equity gap within our countries and across the globe.
Thank you for the story and the perspective.
Maybe one last question here.
Good afternoon, Professor Williams. So thank you very much for a very interesting talk. So his question was about the definition. My question is about the motivation.
Yeah.
So it was very interesting to hear you talk about the coalition between private, public, academic sector. But I was wondering, like, how effective can we replicate this process when there is no pressing situation to align the interests of the three parties, like the pandemic?
Yeah.
So especially the private sector, I would say.
Yeah.
So many of the global health issues, it would be very difficult for the private sector to chip in and gain something from it. So I would love, in your experience, how would you bring the institutions and the companies together to achieve the same goals, even though they initially might not have the same objectives?
Yeah. I think in a lot of ways, and I don't want to make light of this, COVID really hurt all of us. I think all of us have suffered major loss, including our CEOs of the biggest companies. You have to remember that there has been tough lessons learned from all of us. There's not a person in society today that did not escape the ravages of the early first year of the pandemic. Okay? So I say to you, your generation, you have a gift. You have the gift of taking this public health crisis and carrying it forward in your narrative and in the way you practice public health by reminding everybody that a public health failure impacted all of us. It brought all of the world to a full stop. A CEO will get that. Their supply chain was disrupted. Their workers became unavailable. Their clients went home and retreated from commerce. What more can a CEO need to know? Don't miss the opportunity to explain the example of why public health is so fundamentally important at the root of all of civil society, including the commerce, including companies' access to human resources, access to supply chain, access to services, access to consumers. CEOs right now are still grappling with the lessons that they have learned. It's our job to make sure they don't forget it. It's our job to make sure we are constantly communicating effectively so that they connect the dots the way we are trained to connect the dots between upstream and downstream effects. So I say to you that we should open up ourselves to engaging in conversations, to finding opportunities. You know, one of the things I discovered is we have many graduates of our school going into management consulting jobs, but we don't celebrate them. They sometimes feel like they're sellouts. They're not sellouts. They are the link between public health and commerce. Let's engage those people who are at the link to build and create more deep and broad values across the private sectors. When I was recognizing that CEOs from big companies like Disney, you know, and Bank of America and EY, Ernst & Young, they were calling me. I didn't know they knew my name. Why were they calling me? Because they wanted public health help in risk assessment and risk management. And I said, well, okay, public health means business. And I created a lecture series that allowed them to feel comfortable coming to public health and me to feel comfortable preaching public health to them. I found a way to create symmetry. They had what I want, a big soapbox, know-how, operational capacity to make things happen. I just have the abstract concepts of public health. I needed them to implement on things. They needed me for knowledge and expertise. So don't miss this opportunity to leverage the pain and suffering that we've all had. Use it to educate them. Remember I said, collaboration begins with what's in it for me, what's in it for you. Public health has a lot to offer all parts of society. It's a great question, and I will confess to you, 5 years ago, before I became dean, I was just interested in talking to other epidemiologists and other knowledge generators. But if we're really going to have an impact in public health, we have to really work across sectors. We need implementers, and the CEOs and the business community are the implementers. We just have to find a way to make the equation positive and useful for them as well, without compromising our values. It's a great question.
Thank you.
Thank you so much, Professor Williams. And we have an exceptional session today. And we truly learned tremendously from you. And we have a very fruitful discussion between our international student program. Next, I would like to invite Professor Vacharasin to give the souvenir to express our appreciation to Professor Williams. So now our today's session is coming to the conclusion. Thank you everyone for joining us today. SGH will continue to organize the academic lecture series and other events. You can follow us and get more information about our activities on our website. Thank you.